Thank you all very much for coming this evening. My name is Rick Frank. I am the supervisor of the Narcotics Division in the Marion County Prosecutor's Office. Mr. Curry is out of town this week, so you're stuck with a peon. It is my honor this evening to moderate this. Since it has a drug theme, I think it's appropriate that I'm here to speak a little bit about opioids and introduce the two speakers that we have coming. I want to tell you just a little bit about what we do at the prosecutor's office in the drug area. I supervise a division that all we do are drug and gun cases. I have 28 prosecutors in my division that Terry Curry dedicates to do drug cases, along with 8 staff. We have 3,000 pending cases in 4 different courts. Those are just drug and gun cases. And I want to make sure you understand too that we're sort of double focused in that we have 2 courts that deal with basically users, and we have 2 courts that deal with those who choose to deal. So the myth that you hear that the jails are always filled up with those who just use drugs is simply just a myth. It's not true. We take a 2-angle approach that we do actively pursue what the law will allow for those who are drug dealers and those who choose to traffic drugs, especially those who choose to traffic high-weight drugs. But we also have courts to deal with those who have an addiction issue, which we're going to speak of a lot this evening. And we deal with probation a lot with them and substance abuse treatment. And we have a dedicated court that deals with it. We call it our drug treatment court. It has 145 people in it now that if they get through the drug treatment program sponsored by Marion County, we dismiss their case at the end. So there are certainly treatment options available and probation available, and sometimes home detention is a good option for those people to work on their addiction, have a weather on that. And then the other aspect are those who choose to deal and provide the product for those people. We actively pursue Department of Correction sentences for them. As I think you all know, we can disagree on the avenues to combat it, but the opioid surge and the drug problem in general is a huge issue, not only from the numbers that I just told you that in our courts, but in our other courts, either directly or indirectly, the drug issues affect probably 95% of our crimes are affected in some way related to a drug issue. So we're very happy that you came this evening to learn more about it, to help us combat it. I think we would all agree that the prosecutor's office can't do it alone, the police department can't do it alone, those you're about to hear from in the hospital and the health department can't do it alone. It has to be a community effort. We may not be able to do it overnight, but we can chip away at this thing and kind of get things back in order, and this is a good first step for that. So thank you all for being a part of that. We have 2 speakers this evening who have vast amount of experience, and we very much appreciate them taking their time out of their busy schedule to be here. And we're going to kind of go double-pronged here. This is going to be an issue of how the opioid crisis and the drug crisis is affecting our first responders and our healthcare system, and how it's affecting our community in general and from the health department aspect of it. So first up, we have Dr. Krista Brucker. She is a faculty member at the IU School of Medicine's Department of Emergency Medicine. She works at the Eskenazi ER department. I'm sure she'll have some stories about that. Dr. Brucker conducts research that focuses on mental health and substance abuse treatment in the emergency department setting. Her current work includes the design and implementation of Project Point, and she will explain that more to you. It involves those who have overdosed and an effort to get them out of that cycle of overdosing. And that is a collaborative effort aimed at identifying, treating, and linking patients with opioid misuse to the services that are currently available. She has a vast amount of experience. She told me just a little while ago she's been doing it 4 years in the ER, so I'm sure that she's seen just about everything possible in the ER so far. I'll tell you just a few housekeeping issues. Most of you have been here the past few weeks, but there are restrooms outside there. Snacks, help yourself to it. There's some new cream, I think, this evening, I hear. So help yourself to the new cream. Don't feel like you have to ask to get up and do that. We'll have questions at the end. Should be plenty of time for both speakers of questions at the end. So if you have something as we're going along, maybe jot it down and we'll get to it right as we get to the end. So please welcome Dr. Krista Brucker.
Okay, just making sure I knew how that works. So I'm Krista Brucker. My day job is as an ER doc at Eskenazi. So I spend most of my time taking care of patients of all kinds there. And I got involved in Project Point, which is kind of exactly what it sounds like. We kind of meet patients after they've overdosed and work to help them in their next step in their recovery process, whatever that is for them. So I'm really grateful for the chance to be here tonight. We don't do a lot of crosstalk between the criminal justice systems and the healthcare system, and I'm so grateful for the chance to try and start and continue a dialogue. So, I was planning on going after Dr. Kane, who I'm sure will tell you a lot more about the epidemiology and public health side of this epidemic, but 2015 was a really sad year for ER docs. We spend a lot of time training to learn how to take care of a lot of things on this list, including motor vehicle crashes, gun deaths, and gun homicides. We spend almost no time training to learn to take care of people who overdosed on heroin. So this was a real wake-up call for emergency departments and emergency medical providers across the country, including our own. So here in Indianapolis, these are data from Indianapolis Medical Service. They cover most of the county. So you can see this trend line that I think we're all kind of sick of seeing, which is going up and up and up, and also concerning are the number of patients who are needing more than one dose of naloxone. So we'll talk about that. That means both in the one day, so when we go to the scene, they need more than one dose, but also they need to have repeat calls on repeat days during the year. So we'll talk a little bit about that in a bit. Most concerning from a sort of harm reduction or sort of just basic ER doc mentality of saving lives is that when we look back over 5 years of overdose runs, about 10% of people die, and only about 3% of that 10% is from a drug-related cause. So people are dying of a lot of things, not all of them having to do exactly with repeat heroin overdoses, which is an interesting public health issue. For the epidemiologists in the room, if you get a dose of naloxone by EMS, your hazard of death increases by 65%, and your hazard of death from dying from a drug-related cause increases by 200%. So this is a big red flag. This is a way that systems can try and identify people who really need help, that kind of might float under the radar and often aren't engaged in any formal system of care, meaning they don't have a primary care doctor or a clinic that they go to. So the first thing they did when they sort of saw this data, and this was before my time here, was that Dr. Dan O'Donnell, who was medical director for EMS, decided that we needed to push naloxone out to all of the first responders, so the EMTs and also the police. And they did a lot of work in Indianapolis in collaboration with the police department to train all of the police officers to carry and use naloxone. They showed that it was safe and it was effective and that police could do it. And they also worked on legislation to allow for it. So sometimes it's not just showing that it works, but also doing the political groundwork of making it possible. So this is the paper they published. They looked at 126 overdoses that had naloxone administered by police. Police, 90% of whom at the beginning, before they started, said they had seen an overdose. So there's already a lot of exposure to it. They could recognize the overdose appropriately, and most importantly, patients did well. So the vast majority of patients woke up, which is what we hope for with naloxone, and only one became combative. So that was one of the first sort of concerns that people had about first responders and even lay people using naloxone, was that people are going to wake up and be in acute withdrawal and be violent or combative. We just don't see that, practically speaking, very often. So this also led to some attempts with the Marion County Health Department and other community organizations to start training lay people in naloxone use. And we know from experiences, mostly on the coast, but definitely in Massachusetts, about 20% of people who are lay people who are using naloxone are family members. So this is a really important way to empower families that are often in a very, very difficult position when they have a loved one who's suffering from the disease of addiction. We know that a lot of people want to be trained, so there's a lot of community groups and public health related people who are sort of coming out of the woodwork to be trained, which is great. We're very excited about that. And in some communities where these programs have been running for a while, we're actually starting to see trends towards decreased overall death from overdose. So these public health interventions are impacting the epidemic. And these are things that are driven really by community members, by family members, who are kind of stepping up to be first responders. So after Dr. O'Donnell did a bunch of training with the police, they actually came back to the EMS group and the ED group and said, okay, we're waking all these people up, bringing them to the hospital, like what are you doing? Because you're just sending them home. And this doesn't make a lot of sense. If we're gonna wake them up and help you guys out, then you need to help us out. So we had a meeting. Everything starts with a meeting, right? So we had a meeting, and the director of the Indiana Poison Center, Dan Rosiniak, asked this question, like, what would it look like if we treated an overdose like a heart attack? Like, we're ER docs, right? Like, heart attack is our thing. So what would that look like? And for those of you lucky enough to never have had to be swooped into the ED for an emergency like a heart attack or a car accident or a gunshot, this is what it looks like. So they come sort of rushing into the highest acuity areas. This is 3 doctors and 3 nurses and a tech, and then there's probably 10 to 15 more people standing outside. So that's what happens if you come in with a heart attack or a gunshot or a bad car accident. All those people appear and are on standby for you for whatever you need. And then if they don't need your services, you go back to doing whatever you do. This is in stark contrast to what happens if you overdose and come to the emergency department. So you kind of just come in by ambulance and get put in a room. Someone probably puts you on a monitor, and then we kind of watch you for anywhere 2 to 6 hours to make sure that your oxygen levels are okay, that you don't need more naloxone. And then in the vast majority of emergency departments, including my own before Project Point, most people were sent home with a piece of paper that said, here's some phone numbers, good luck. So we designed Project Point from this idea of what would it look like ideally? Like if you had all the money and none of the politics and you could just do whatever you wanted, what would you do? So we would still do, you'd still have a referral or this sort of alert from EMS when there's an alert, when there's an overdose, so you know who the patients are, because that's the first problem. You got to get the right people to the bedside of the patient. So the ERs would still do the same thing they usually do, make sure your oxygen level's okay, you don't have a bad infection, you don't need more naloxone. That all happens like it usually does. But then we do what in the literature is called a brief intervention. So we started by using clinical social workers to sort of go to the bedside of the patient. We've actually now moved towards a recovery coaching model, so a peer support person, that's someone who has lived experience with addiction, who actually, once the patient is stabilized, is sort of called to their bedside to do the brief intervention. It's really not that complicated of a thing. The first thing they try and get to with the patient is what happened today. So what we know about people who use heroin with some regularity is that they often use multiple times a day, but actually overdose very rarely. And so the first thing that we try and get at is what happened today, because the other days that you've been using you didn't die, but today you died. So what happened? Because we want the first thing that Point does is try to keep people from dying, which I think sometimes gets lost in all the chatter. So what happened today, and how can we help that from happening again? Did you use a different amount? Was it from a different source? Did you inject it instead of snorting it? Were different people around? So maybe normally you use with someone and have kind of a system. Maybe you used alone today. Maybe you were in a gas station or an unfamiliar location. We know you're much more likely to overdose if you use in a new place. So they go through all those kinds of things. And sometimes we get some pushback about oh, you're just teaching people how to use drugs. No. They're using drugs. We're teaching them how to not die. Okay, so at least that's how we look at it. The other thing we do is offer HIV and hepatitis C testing to all of our patients. This is really scary. So I'm sure a lot of you know about what happened in Scott County, almost 200 new cases of HIV in 2015 and 2016. 90% of those people are co-infected with hepatitis C. So that's devastating to a community. It's also a financial catastrophe. So the lifetime estimates of cost for treating HIV, between $200,000 and $400,000 a patient just for HIV. Hepatitis C is another $80,000 at least on top of that. So there are estimates from the health department that if that kind of epidemic happened here in Marion County, because of our greater population density, we'd be talking about $500 million treating HIV and hepatitis C over the lifetime of these patients. So if for no other reason than you're a tax-paying citizen of Marion County, there's a very good reason to care about this stuff. So the point is we HIV and hepatitis C test them because a lot of people aren't connected to care, so they don't have anywhere else to get tested, and they're a very highest risk population. And then we also provide an naloxone take-home kit with teaching, so our nurses actually provide the kit and send the patient or the family member out with the kit, so they don't have to go to the pharmacy and try and figure out insurance and how to get it. They see a financial counselor to try and get them connected to the insurance systems that might be available. Most of our patients qualify for Medicaid or HIP, so we're pretty successful in getting people coverage. And then we make a linkage to care. So we've spent the last year and a half like pounding the pavement trying to figure out who can take what, where, when, at what time, with what insurance, to figure out transportation. Housing is a really big issue, so a lot of people who've overdosed have alienated most of the people in their lives on whose couch they could sleep, and so we do a lot of work with emergency housing. And then a lot of the work that we do comes in urgent follow-up. So in the past, we would sort of let people go, and the approach was, well, if you want help, you'll come find us. Turns out that doesn't work very well, especially not when you have the disease of addiction. So we do a lot of community-based, phone call, text-based follow-up. Hey, how are you doing? What do you think about maybe talking to us? You don't have to go to treatment. You don't have to do anything. We just want to check in and see how you're doing. So we call it very low threshold services to try and kind of pull people, coax people in who quite frankly have a lot of skepticism about any bureaucracy's ability to help. And some of it is well warranted. And then of course the idea is that we engage them in some kind of long-term treatment, so transition them to one of our behavioral health providers so that they can be in treatment. We know that people who get somewhere between 6 months and a year engaged in treatment, any kind of treatment, have much, much higher rates of long-term recovery than people who bounce around between treatments or stick with us less than a year. So we put a lot of effort in up front to try and connect people. People always ask what it looks like, so I just finally took a picture of our weekly meeting. So this is the group. There are some community-based paramedics there, and then we have an addiction psychiatrist, myself, and then the people who do the brunt of the work, 2 recovery coaches and a licensed mental health counselor. We talk about all our new patients, and then all the patients we're following to see what kind of issues we can help with. I'll tell you anecdotally that probably we spend 90% of our time dealing with what I would call non-medical issues, so housing, childcare, transportation, insurance, which requires, DMV and vital records sometimes. There's just a lot of places a lot of things people have to line up to be able to engage in care. We were not the first to think of this idea, so I always try and remember to point out some other places. The first and probably most well-known is Anchor ED, which is in Providence. Baltimore's county actually, or Baltimore runs their program out of their health department and covers multiple hospitals. New York City has just started a program sort of deploying recovery coaches. So I think this to emergency departments, I think this is catching on. And probably the leader in the emergency department care of overdose patients is Dr. D'Onofrio, and she's in New Haven. They actually randomized patients to start buprenorphine or Suboxone in the ED. They go home with a script, so no more you have to follow up and this and that. You just get it right here. We're going to help you right here, versus regular care, which for them is kind of the referral that we were talking about. So their 38-day follow-up rates jumped to 78%. 80% of their people are getting into care when you start the medicines right there in the ED, versus 35% if you provide a referral to a treatment. So I'm going to just talk a little bit about what we've learned. I am sort of I'm not at all an expert in this, but we have learned a lot, and we've learned a lot from the fact that we interface so often with patients who actually use drugs. I think a lot of the conversations that have been circling locally and at the state level really lack a perspective from people who actually are dealing with this disease or family members who have people in active addiction. So I do think that there's a lot of experience to be pulled from what we've done. So if you don't remember anything else from anything else I say tonight or anything I show you, the vast majority of people who overdose on heroin and end up in our emergency department want help. They do. Like they're not, when we started this, everyone was like, oh, they just want to go out and get high. They're not even going to let you in the room. Not true. So 89% of our first year's patients wanted a referral to care. Okay, that doesn't mean 89% got into care, but 89% of people said, yeah, sure, come in the room, tell me what you can do, like I'll let you try and help me, which is not what we expected. And then a lot of people are interested in our HIV and hepatitis C testing. The naloxone is newer, so I don't have those data yet, but most of our patients are willing to take home a naloxone kit. So one of the things that this year and a half really taught me is about just how incredibly dysfunctional our healthcare system is. So, and of course patients' families are the ones who say it best, but you know, this is a mom who had been to the ED 6 times in the last 4 months. And you know, we came in to help, and she just kind of was at the end of her rope. And as an ER doc, like there's not a lot, we give a lot of bad news. I mean, I see a lot of really sad stuff every day. But the absolute worst thing is not, like someone's here for help, their family member is like in a state of crisis, and we're like, oh, okay, well, you know, there's not a whole lot we can do. And even with a year and a half of experience getting people connected to care, it's still a struggle every day to make sure you have the right insurance and you can get there, and they'll take you, and they have a bed. And it's not because any of the systems who treat addiction are bad or bad people or doing bad work, it's just completely overwhelmed. So most of the places that we work with have long waiting lists and are thus limited in how long they can keep people. So this is, I think, what I can tell you is that about half of our when we started, about 4% of our overdoses were showing up at their first anywhere for treatment. After we did our started point with just the brief intervention in the emergency department and kind of helping shuttle people or refer people with what we call warm handoff, that rate jumped to 50% of people that we got into care. You can see what is a very concerning trend, so I'm not here to just tell a good story. Like, it's still really hard to keep people in care. So, and then on the end there, you can see active on bupe and active on methadone. So those are the last three are the 3 FDA-approved medications, and you can see that the vast minority of our patients have access to those medicines. So, or at least getting on them. So that's concerning to me. Luckily or unluckily, I don't know, we're not alone in this. So this is a sample of discharged patients from inpatient units that have private insurance, so presumably don't have an insurance barrier to care. And you can see that 40% of them are getting no follow-up services. Another 40% are getting therapy only, and only a small minority are getting, again, on the medications that we know help treat this disease. So this is not just an Indiana problem, which I know you all know. Okay, so this is a busy slide. I'm not going to go through it completely, but there's, not only are we not great at getting people into care, providing services that people need, we're also actively, as the healthcare system, we're also actively contributing to the problem. So of our overdose patients, in the year before their overdose, 60% of people were prescribed an opiate, and 12% actually had an active prescription at the time of their overdose. That's sad and that's bad, and I think there's a lot of work being done to try and help. What's really embarrassing and really sad is that 1 in 4 were re-prescribed an opiate within 3 months of their overdose. So that's terrible. So part of the problem is that it's hard for actually to know that your patient has overdosed. So Inspect, which is what we use to sort of track prescriptions, doesn't report overdoses. So if you're a primary care doc prescribing oxycodone to your patient for chronic pain and they overdose and go to a different hospital, you might have no way of knowing. So there's a lot of work at the systems level that we're trying to do to help the healthcare system stop contributing so much to this problem. You can also see that the average number of scripts and the average number of providers is very high. So, 5 and 15 or so. So that's a lot of different people writing controlled substances for one patient. It's going to be really hard to keep people safe if you have that many different doctors trying to manage things. The other thing we learned pretty quickly is that this is, for a large majority of our patients, not just a substance use disorder. In fact, about 55% of our patients had seen Midtown, which is our community mental health provider, before they overdosed. So this is not the idea that we can just fix this problem by getting people some more different pills. There's a lot of underlying mental health issues that also need to be addressed. I just pulled out some quotes from our first year of talking to patients. And we hear this a lot, that it's hard to access mental health care services, people are frustrated with medications, and a lot of people are using heroin not to get high, but to just like slow their mind down a little bit. And I know there's probably some eye rolling going on somewhere in this room because people who use heroin have lots of different motivations, but I don't think we can deny that this is a part of why a lot of people use, because they're suffering in ways that the medicines we have, the tools we have, the behavioral health system we have is not reaching. To be clear, I don't recommend it as a treatment for mental health issues, but I do think that's what we see actually a fair amount of veterans who are dealing with PTSD who are using heroin, again, to just kind of escape. The other thing that we found out very early on was the role of childhood trauma. So if there's a tool that's been developed called the Adverse Childhood Experiences Score, and it scores on basically 3 different domains. The first is abuse, so physical, emotional, and sexual abuse, and then also on neglect. as well as what they call household dysfunction, which we see quite a bit of. So that's people in the home that were either incarcerated or have mental illness, as well as domestic violence in the home, substance abuse in the home, and then divorce. So each of these 10 things is 1 point on the ACE score. We know from lots of studies in lots of different areas that ACE scores of 4 or more correlate well with increased risk of all kinds of things, including cancer and heart disease, suicide attempts, substance use disorders. And so we've started tracking it in our patients. The idea is that if you have an adverse childhood event or experience, that affects how you develop your cognitive, emotional skills and your sort of capacity to manage stress in healthy ways. And those lead to the adoption of, usually in adolescence, high-risk behaviors. So we know that a lot of addiction specialists think that this is actually a developmental disease, and that if we can intervene early, like in very late childhood or early adolescence, we could head off a lot of these problems by avoiding the adoption of these high-risk behaviors. We know if we can get you to about 22 and you haven't developed a substance use disorder, that you have a high likelihood of going on to not develop one. Obviously, that doesn't mean that no one over 22 develops that. And then obviously those high-risk behaviors are what lead to the health problems, which then leads to early death. This is another thing that you can't escape or avoid, and any program that's going to address this issue, like really address this issue, is going to have to take this on. So in our patients, about 60% have a score of 4 or more. So 60% of our patients had 4 or more of those things happen to them. These are really sad stories about sort of surviving very chaotic childhood situations. And the bottom one gets me every time, which is my mom gave me my first hit at 8. So, you know, whenever you're feeling like, why do people do this? If you just even remember that one story, it might help you kind of regain the compassion that's so easy to lose because the problem is so overwhelming. I do want to point out that there are plenty of overdose patients who have scores of 0 or 1, which means that this is obviously not the whole solution, the whole problem either, but it is definitely a part that I think doesn't get talked about enough. Okay, so I don't want to leave you all like down in the dumps, because actually this work is very rewarding and fulfilling. I know that was a lot to take in. I think there are some things, and I think as this change, you know, the change that's happened so far, the money that's coming in to help, the political landscape that's changed has come really from community members and community organizations, and particularly family members of affected loved ones. So I don't know, I'm not exactly sure how you guys are gonna take all of the information I'm gonna give you, but I'm gonna just tell you what I think, having done this work for 18 months, and you're free to form your own opinion. So be open to medication-assisted therapy. So there are 3 FDA-approved medicines for the disease of addiction, specifically opiate use disorder. The first one, and most well-studied with the best evidence base behind it, is methadone. The second is buprenorphine, which you might know as Suboxone or Subutex. And the last one is naloxone or naltrexone, which has been around for a long time, but recently reformulated in an injection form that can last 30 days. So the difference between these 3 medicines is that methadone, basically, your brain works in a sort of a lock and key model. And so heroin is sort of the key that goes in a lock, and that's how it has its effect. Methadone is a similar key that goes in the same lock, but instead of giving you a high that goes up and down in 2 to 4 hours, it gives you a very slow onset, and it covers you all for full 24 hours before you're dosed again. So instead of getting that up and down high, you just get this sort of steady replacement. So the idea that methadone is replacing one addiction for another is really not based in any science. And we'll go over a little bit more why it's so important to have that steady level instead of those ups and downs. Buprenorphine is an interesting one. It is also a key that fits in the lock, but it is hard to get that key out of the lock. So if you use heroin, while you have that key in the lock, it can't get in. So it both kind of, it both kind of fills the lock, but it also prevents heroin from getting you really high, in theory. Obviously, none of these medicines are perfect. They can all be misused. They can all be diverted. Okay, like we're not going to pretend like this is magic and there's no risk to them. But with my ER doctor's hat on, I would much rather you be misusing Suboxone or buprenorphine than misusing heroin, because it's very hard to die from an overdose of buprenorphine because it has what we have a ceiling effect. So the more you take, you don't just keep getting more and more problems breathing are more and more high. It just sort of levels you out. So once you've taken the prescribed dose, if you take 10 more, you're not going to get that much more effect from it. Vivitrol, or long-acting naltrexone, is very appealing because it basically completely blocks the lock. You can't stick anything to it, and if you put a whole bunch of heroin in your blood, it's blocked up so it can't get in. It's also appealing because there are 30-day formulations, so you need one shot every 30 days to maintain that effect. There are now longer implants, buprenorphine implants, so hopefully those will also, and actually they're working on a long-acting buprenorphine shot. So hopefully all these medications will be available in long-acting form so people don't have to take them every day. This is part of the reason why it's so important to have something on board. So this is sort of the cycle of addiction. So at the very far end, there's a laser on this one. No. Okay. At the very right-hand side is when you start using heroin or any drug of abuse, you get really high highs, and then you kind of come back down, not too far below where you started at that white line. But as you move as you continue to use and your body becomes dependent, and then you develop a substance use disorder, the highs get much lower and the lows get much, much lower. So when you hear people say, I'm dope sick, or I'm using just not to be sick, or I'm using just to feel well, that is really very true. Like most people who've used heroin for more than a few months are not getting the euphoric feel-good effects. They're literally just using because they just want to feel normal. And we hear that from a lot of our patients, especially patients who are trying to feel better. So that's not just a lie that people who use drugs tell you. That's actually borne out in the science of this. I know this is a little sciencey, I'm sorry, but I just have to show it to you because you basically have two parts of your brain, the sort of reptilian part of your brain that's very old and geared towards making sure you survive in a very scary world. And then you have another part of your brain called the cortex, especially the prefrontal cortex, which manages things like judgment and making lists and making good decisions, what we call executive function. So basically your prefrontal cortex spends a lot of its day telling your reptilian brain, no, don't do that. Don't do that either. Don't do that. Don't eat that whole piece of cake. Don't drink that whole bottle of wine. That's all your prefrontal cortex telling you. So when you eat food, this is a rat model. So when you give a hungry rat food, you see this little spike, and that's your reptilian brain telling you, yeah, do that, because that's good for your survival. So that little spike of dopamine feels good, and it connects to your memory system, and it reminds you that you should eat, because it feels good. Same thing happens for sex, which is also good for survival of the species. Okay, so the scale here is 0 to 200. The scale here for amphetamine, which is part of the reason amphetamine is so problematic and so addictive, you feel that dopamine jumps from 1, 200 to 1,000, 1,100, 1,200. So when you use amphetamine, you feel an order of magnitude better than you felt on the best day of your life, right? The very best day of your life, you feel that much better. So that is obviously a very rewarding, and I actually, instead of the reward pathway, I like to call it the survival pathway. So that's your reptilian brain telling you, yeah, that was really good for survival, do that again. So this is how drugs hijack what's a very healthy mechanism in your brain to keep you using more and more and more, and to keep you doing stuff that you would never do. You would never leave your kids at home alone to do, that's your prefrontal cortex saying, no, it doesn't matter how good that feels. I'm not leaving my kids home alone to go do that thing. But when your brain is hijacked, it literally feels so good that it overrides what your prefrontal cortex, your sort of human brain, is telling you to do. And it's true with anything you can get addicted to. So not just drugs, but all kinds of behavioral addictions as well. Tickle this exact same part, this exact same dopamine in that reptilian part of your brain. So when people say it's a chronic brain disease, they're not just waving their hands and saying that because they want you to, I don't know, it's exactly what's happening in your brain. It doesn't mean that there's no decision-making process. We know lots of people who've conquered this disease of addiction and who have not used drugs for a very long time. So obviously it's possible, but it's really hard to tamp down that reptilian part of your brain when it's screaming at you, do that, do that, do that. And you just have this tiny little voice up here in your prefrontal cortex saying, don't do that. So the whole idea of medication-assisted treatment is that if we can get you steady on that white line, then maybe instead of this up and down cycle of yes, yes, more, 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 maybe your prefrontal cortex can slowly start to recover and tell you no, no, no. So that's more pictures proving it. If you don't believe any of that, what we know from real studies is that places that have more access to methadone and buprenorphine have lower overdose death rates. So if you're here because you care about people dying of overdoses, then allowing access, providing access, encouraging access to therapy is the right way to do it. This does not mean that people just get a pill and that's all they need. It means that in addition to the behavioral health services that they need and all the wraparound services they need and all the community support they need need medicine. And they need it up front because that's what allows your brain to start refunctioning again. And so it's that. The other thing that might be controversial here, I don't really know, is a needle exchange and naloxone. So these are what we call harm reduction services. Here's our data. So 80% of the people who tell us, they come to the ED and say, I know I have hepatitis C, 80% of them are sharing needles. That's terrifying. And we know from studies in lots of other places that clean needles are a key part of preventing the transmission of disease. And like we talked about earlier, preventing transmission of disease makes good economic sense. Okay? Same with naloxone. Although a lot of our people now know about naloxone, very few of them have access to it. So over half of our patients tell us they know what it is and how to use it, but only 3% have it. So a lot of people think like, oh, the naloxone work is done. We've given out a ton of naloxone. But most people, especially these very high-risk people, still don't have it. The last thing I'll tell you about naloxone and needle exchange is that if you're a parent or have a loved one who's suffering, there will be a point, usually in their addiction cycle, where you cannot reach them, where they are gone, they're missing, they're in a cycle of active addiction, and you can't reach them. But that doesn't mean that nobody can reach them. And sometimes naloxone and a needle exchange is a way to say to a patient, I know you're using, and I know you're gonna leave here and keep using, but I care about you. And I want you to be as safe as you can, and I'm gonna give you this needle, or I'm gonna give you this naloxone kit as a way of saying to you, I care about you. And I'm gonna be, maybe the only person you interact with that isn't a dealer or a friend who uses, or a family member who uses, or someone who's trying to trade you something for drugs. So I think it's a really, beyond its financial and medical sensibilities, it's a really important part of the chain of care that if you had a loved one who you couldn't find and was out on the street using heroin, you would want them to have that one little spot of light in their milieu. So that's what I would say about overdose naloxone kits and needle exchange. So I hope you all will be supporters of it here in Marion County so we can keep moving on it. I think there's a bunch of thank yous here. Tons of people have helped make this work possible. That's all I got.
I will not ask you to raise hands, but I would guess if I did, almost everyone in here would raise their hand if I ask if you have some connection to someone who has either overdosed or been arrested or been involved in the criminal justice system or in some type of the process that the doctor was just speaking of. It's a problem that is almost so big sometimes that even us at the prosecutor's office sort of loses perspective, I guess, if you will. And something that Dr. Brucker said, I wrote it down because I'm going to remind my staff tomorrow. She said the compassion is easy to lose because the problem is so overwhelming. And that's pretty awesome to think of, really. And it's good that you're all here because we need to make sure we keep that in mind as we go forward on all of that. And if I did ask to raise hands, it's because this problem involves the whole community. And that's what our next speaker is going to speak directly about. And the different programs that she's involved in that maybe we can take another little chip out of solving this. Dr. Virginia Kane is the director of the Marion County Public Health Department. Under her leadership, the agency has generated over $18 million in federal and foundation awards in the past 5 years. She's addressed things like adolescent pregnancy, infant mortality rates, care for the underinsured, underserved populations, potential sources of lead contamination, and immunization rates. Dr. Kane served as an advisor to the National Institute of Health on AIDS clinical treatment guidelines. She served as the Robert Wood Johnson Foundation Leadership for Healthy Communities on that National Advisory Committee. And she is also an associate professor of medicine for the Infectious Disease Division at the IU School of Medicine. We are very happy that she has taken some of her valuable time to spend with you and us this evening. Please welcome Dr. Virginia Kane.
So I'm going to summarize about how our opioid death rate is much higher than a lot of the other larger major cities, and that we have seen with our ambulance runs how we've almost tripled the amount of runs from 2011 to 2016 from an overdose standpoint. I'll give you some large numbers. But what's even more frightening for us is that we've seen a significant increase in hepatitis C infections, 4 times an increase, primarily from injection drug use. And would you believe Indiana ranked #1 in the country from pharmacy robberies in our country? And I'll talk to you a little bit about how Marion County makes up a significant number of those robberies. And we've had 4 times an increase lately with our law enforcement folks doing these heroin seizures that are coming into Indiana. Let me just say why we're really unique. We're one of the few cities that is connected from so many different geographic areas by transportation that it's really easy to get drugs into our community compared to any place else. It's a very easy access from the east, from the west, from the south, making it very, very incredible. But I'm also going to talk to you how heart-wrenching it is to see the number of children now that are being placed in foster care because they really have no parents able to take care of them. So when we look at the opioid death rate, Indianapolis and Marion County, from 2012 to 2014, we went from about 17 deaths per 100,000 population. Our total population in Marion County, Indianapolis, is about 985,000 people. So we have about 17 deaths per 100,000. Just in a 2-year frame point, we went up by about 5 deaths. So up to, rounded off to 23 deaths per 100,000. But what I will highlight to you is, oh, I thought that was a pointer, but I guess it wasn't. Sorry. Maybe this is the pointer. Well, let's use the pointer to the side. Well, what this slide will show to you, Marion County is the one that's in that orange bar. But the other cities below that, the U.S. total for drug overdoses, the national total is no more than 5 deaths. So we're at 23 deaths, okay? But we're beating Las Vegas. So, you know, we have more deaths than Las Vegas. Now, what does that tell you? People enjoy gambling more than they do using drugs, all right? We're beating Minneapolis. And I think it's just too cold up there for them to use the drugs, okay? All right? So these are why they have advantages over us in some of those other cities. And even Phoenix, Arizona is just so hot, who wants to do anything? Okay, all right. So they have advantages that we don't have. So let's see here. So what's frightening is, in 2016, last year, we had a total of 270 deaths from an overdose. 270 people died from an overdose, okay? Now, back in the year that's 3.6% of all the deaths that are occurring in Marion County, natural causes or whatever. Back in the year 2000, we only made up, drug overdoses only made up 0.4%. We're now already at 3.6%. And look, that slide, you can see it's just steadily climbing every year. So, if we broke it down by race, what might surprise you is to see that the white residents from the drug overdose has increased 12-fold. They are the highest group dying or having fatal drug overdoses by race. So back in the first part of and that's that tall purple line going up. So back in 2000, they only had 17 deaths, 2000. Fast forward to 2016, and we had a total of 207 deaths of white residents. Now, following behind them is our African American population, and they started out at, I want to say, probably somewhere around about 10 deaths back in the year 2000. And now we had 58 deaths last year from a drug overdose. We had 5 Hispanic Latino overdoses last year. But one of the fastest growing folks for the drug overdose is young, in their early 20s to early 30s, white residents in suburbia, sometimes in rural areas through the state of Indiana. So if we looked at it by gender, females in the pink and the males are in the blue. We saw a tenfold increase in our males having these drug overdoses from 2000 to 2016, but the females are not far behind at about an 8-fold increase. So they're not quite catching up with the males, but proportionally, you see that they're climbing just as quickly as their male counterparts. Now, if we look at it, also, you should notice that we've had our accidental overdoses, drugs, deaths taking place, and that's increased. So we've had people having accidental poisoning, and that's those bars that are in the red and whatever. So they're just overdosing by an accidental poisoning. Now, the suicide is that in the green, the light green. So we're still having a significant number of suicide deaths, which is intentional, but it's primarily the red that's the overdose cause. Now, I don't know where you live, but I've highlighted for you those drug overdoses, and this is a 3-year trend. So we looked at 2014, 2015, 2016, and we totaled the cases to see where you can see the highest concentration of overdose deaths. Now, that is just showing the residents. So, you know, I can overdose on a drug, but that's not where I live. So what I'm showing you are the folks who have overdosed. This is their residence of location, where they live, not where they're actually doing the drug overdose. So as you can see, those zip codes 46201, 46203 are the heaviest hits, followed by 46222, 46241, 46227, and even 46219. So those are the heaviest hitters. But now, where are they? Oh, shoot, I'm sorry. Let me go back. That shows on this far slide the location of where they're actually having their occurrence of drug overdoses. And so that may suggest that's where we have the highest number of people who are the drug dealers who may be selling them their drugs, and they're not waiting to get home, and they're doing their drug overdoses in those particular, the darkest blue locations. Now, if we looked at the overdose ambulance runs, in 2014, we saw 687 in non-fatal emergency department visits due to an opioid overdose. So 687. So they were fortunate enough that we were able to catch them early enough in time, and they did not die in 2014. But let's look at what our EMS services saw from 2011 to 2016. So way back in 2011, it's hard to see that slide, but they had 565 patients come in for an overdose. That was in 2011. Fast forward to 2016, we had 1,818 patients come in for a drug overdose. 1,818 overdoses. So, and from 2015, that was like 1,200. So we are really increasing substantially each year the drug overdoses. Now, Dr. Brucker mentioned about mental health, and I need to highlight and tell you that when we did our Marion County health assessment, we found out just for our 18 to 25-year-olds, just 18 to 25-year-olds, 48% stated that they were so depressed more than 14 days in the past 30 days that it was very difficult for them to carry out normal activities. Let me repeat that. So in their last 30 days, they said greater than 14 of those 30 days, they were so depressed they couldn't carry out normal activities. And of our 18 to 25-year-olds in this community, 48% said that. If you looked at our young children who are 12 and 15, almost somewhere between 12 and 15%, 12% are saying they're depressed. So we're seeing a much higher rate of depression in our younger children, and it gets greater by the time they're 18 and 25. And for whatever reason, they don't have access, or it's a, I don't want to be labeled having a mental health problem or depression. They start self-medicating themselves in order to feel good. So that's an issue. You know, we've got to get rid of the stigma associated with mental health. You know, it may be a lack of my dopamine receptors in my brain. Okay, well, I'm depressed. You need to, you know, just like I may have a deficiency with my blood pressure medicine, and I'm taking my blood pressure medicine in order to address my blood pressure, it's the same that we may require for mental health, but it's how we educate folks. Our brain is our most important part of our body. And so, really key things to look at. Now, this is the pharmacy robberies. In the last 5 years, Indiana leads the nation in total pharmacy robberies at 499. In the year 2015, Indiana had more pharmacy robberies than any other state. Marion County had 132 of those Indiana's 175 pharmacy robberies. The entire state of California had fewer pharmacy robberies than Marion County. Okay? So in Marion County, 87% of robberies were with the same retailer. So CVS now has installed special narcotic safes in approximately 150 of their Indianapolis stores in late 2015. And guess what? Our pharmacy robberies dropped. Okay? So we saw a decrease of 68%. So it depends on, you know, you get what you pay for. So they put the right safes in there. So we only had 42 of Indiana's 78 robberies. And Indiana now ranks number 2 behind the state of California, okay? Although Marion County had fewer robberies last year, this could mean that Indianapolis is seeing those drugs stolen elsewhere brought into the streets to be sold. So there's still a huge market here. It's just that now they just can't use our drugs from our drugstores. They have to go outside. Okay? It may cost them a little bit more. IMPD, Indianapolis Metropolitan Police Department, reports that they had heroin seizures have increased from about 300 grams in 2012 to more than 13,000 grams in 2005. They have been busy, okay, working really hard attacking this heroin issue. When we looked at the increased heroin use and trafficking, we know, unfortunately, that this leads to increased homicides. And in 2015, 2016, we saw some record-setting years for homicides. So we went from 108 homicides in 2010 to 157 homicides in 2016. And hey, it's significantly related to drugs. In 2015, Marion County had 426 non-fatal shooting incidents with 473 victims. So these are the ones who survived. Okay, they've been shot, shooting, but they didn't die. Former IMPD Chief David Allender attributed this increase in shootings and homicides to more drug trafficking and increased heroin use. So, and that's just highlighting we saw a rise in the homicide rate, but Cleveland, Ohio is beating us. Detroit, Michigan is beating us, okay? But we're still ahead of Miami, Phoenix, Arizona, Minneapolis. You know, I told you it's too cold for them to shoot out there in cold weather. All right? And the national average, okay? So when we look at firearm reported mortality, we went from an increase of 16.8 to 19.8 per 100,000 from 2012 to 2014. So only Detroit now is beating us in the firearm-related mortality. And we just compare ourselves with the 30 largest cities, so when we're looking at that. Now, Dr. Brucker mentioned this, and I'll reiterate this. This is one of our major concerns with this opioid surge that's happening. We're very concerned from an infectious disease standpoint. I'm a bug doctor, okay? So infectious diseases, all right? And so we're concerned about the spread of HIV infection, and we will be spread about hepatitis C. Austin has a population of 4,200. And they saw more than 200 HIV cases of HIV and 167 hepatitis C cases. And since that time, it's 90% of their cases of HIV now has hepatitis C. So they got a co-infection, a co-whammy. Not just HIV I got to worry about, but now I've got to worry about hepatitis C. The Centers for Disease Control and Prevention came down and talked with the Indiana State Department of Health and the local health authorities in Austin's population and recommended that they really needed to implement a program called syringe exchange. And that is, stop sharing these needles. So what would happen is you could have like 8 or 10 people in a room saying, oh, we're going to be using drugs together. They have that one needle, they share that one needle, and if you got someone that's both HIV infected or hepatitis C, and it only takes a minute drop, I mean, you can barely see it, to transmit that hepatitis C and HIV, so that one person's infected, and he's sharing the needles with the other 7 people, though they can easily get infected, all of them that same day. And they've had cases where they have generations of folks that were using the drugs. So, you know, the parents, grandparents, you know, parents, and then their young teenagers and whatever, they brought them into the habit. So, really difficult things to do, but we found out when they implemented this program that they had a reuse of the needles by clients drop significantly. They were not sharing it with other people because they could get a clean needle. They were also educated so that they wouldn't overdose themselves. You know, we have, what's the guy, Prince, I think, died of a fentanyl overdose. It's the medicine that you cut the drugs with and whatever. And so, you know, I'm sure he didn't want to kill himself. But, you know, without proper education and whatever, it's easy to accidentally resulted in a mortality related to this. So fortunately for us so far, our HIV-related death rate has dropped, and from 2012 to 2014 from 2.8 to 1.5. Now, you know, Austin's not that far from Indianapolis. I think it's a couple of hours drive. And I'm just telling you, it gets tough for me standing on the highways keeping HIV out and keeping hepatitis C out. But it's getting winter time, and so, you know, I can only stand for so long on these highways trying to keep infection out. But our rate is lower than the United States as a whole, okay? So we're doing a fantastic job so far with our HIV rate. And look at Miami, Long Beach, California, even Minneapolis has a greater rate of HIV than Marion County at 1.5. But it all depends on resources. Resources is the key to addressing HIV. We have to thank Ron White, who really put a stamp on Indiana and helped us to get federal dollars in order to address HIV. And so we're very fortunate to pull Ryan White dollars into Marion County to the tune of about $4 million to really address HIV that we get every year. So a lot of work goes into this. So when we look at our HIV diagnosis, we've relatively remained stable. But we are higher than the United States as a whole in terms of new diagnosis for HIV, but still the rate per 100,000 people, we only went up by about 1%. Now, let me tell you about hepatitis C real quick. And it's a contagious, it's a virus, it's contagious. It mainly causes cirrhosis of the liver. You've heard of that. You know, some people get it from alcohol use, and some people, you just get it, you know, it just happens. And it's not no etiology or real cause, but it can occur. But this virus one is spread primarily through the blood of an infected person, sharing their syringes or equipment. We've sometimes seen it with people getting tattoos, that they don't clean their instruments with the proper disinfectants like they should, that's EPA approved, and so as a result, as they're tattooing, sometimes you can get hepatitis C as a result of that. That's why it's so important that anybody doing piercing and tattooing have to be licensed and everything, that they have the approved products in order to use related to that. But hepatitis C is the #1 cause for us people to get a liver transplantation. You need a liver eventually. And it can be acute or chronic. And CDC data suggests a new epidemic of hepatitis C in predominantly white, suburban, and rural young people and new injection drug users. Short-term illness occurring within the first 6 months is what's called acute hepatitis C. Now, frightening part, 80% who develop hepatitis C, they have no symptoms. They're not sick. So they don't even know they have hepatitis C. They're unaware that they have it, okay? 75 to 85% of them go on to develop chronic, lifelong hepatitis C. It doesn't spontaneously go away on its own. And CDC estimates we've got 30,500 cases of acute hepatitis C infection reported in the United States. And because it's asymptomatic in the majority of patients, we estimate that whatever your actual cases of hepatitis C, multiply by 13.9 times, and that's your actual number of hepatitis C cases you have in your community. They've done this prediction tools out there that can predict and actually know how many cases you have. So from 2013 to 2016, we saw a 4-fold increase in our hepatitis C. We went from 7 cases to 30 cases, okay? And 80% of those cases was from someone using drugs, injection drug use. And don't forget, so if we actually had 30 cases in 2016, multiply it times 13.9, then the true burden of new cases of hepatitis C virus in Marion County is about 417 new infections we had last year. If we predict what we're going to see in 2017, we think we're going to have a total of 945 new cases of hepatitis C in Marion County. Okay. And it's roughly, we're seeing it in the 20 to the 34-year-olds. We're seeing the majority of our cases. The gender is, it's almost equal in 2015, male and female who's acquiring it. Both have seen a rise in the number of cases, but the numbers are small, so sometimes they may be unstable for statistical significance. But if we look at it by race, you can see that, look at it by race, the blue line going up is our white patients. So it is steadily climbing, and all others, you're seeing it's sort of a little slighter increase, not as rapid and sharper increase compared to the other races. So I just want to remind you, long-term illness causing an impact on a patient's body, 60 to 80% of them have no symptoms until they get liver problems. 5 to 20 develop cirrhosis over a period of 20 to 30 years. We need your liver to help when you're getting medications. You know, it helps to metabolize your drugs. So if that's not happening, if you've got damage or scarring of your liver, it can't function, and it helps reduce and remove a lot of your toxins that you ingest or take in your body. So if it's scarred or damaged, it's very difficult to do that. And we estimate as many as 4 million people are living in the United States who have chronic hepatitis C. How does that compare to HIV? Well, we think there are a little over 1 million people in the United States who have HIV/AIDS. Hepatitis C is 4 times the amount that we're seeing as a viral infection. Now, this is a risk slide, but it's really simple. So, if you're an injection drug user and you are living with HIV, about 8 out of 10 patients who fit that criteria will develop hepatitis C. Okay, their risk of getting hepatitis C is 8 out of every 10 people. If you're an injection drug user and you've been using for over 10 years, 9 out of those 10 individuals will develop hepatitis C, 9 out of 10. So if you want to be one of 3, every 3 people, only one of you, that's if you are an injection drug user, you're under the age of 30, and you've used less than 9 years of use, okay? Otherwise, you're going to get hepatitis C. So the frightening part is, okay, we've seen a significant 64% increase in those 213 and 215. Have you seen the pictures where you've seen patients, they got a couple, both of them were in a truck, and they pulled over, and they both were drug overdosed and out, and they had a young baby in the backseat of the car. You might have seen what looked like a young mom. Car door open, she drugged overdose, little baby in the crib, backseat of the car, okay? And so in 2013, we had 2,300 children were removed from the care of their parents. In 2015, that number rose to 3,776 children have been removed from their homes because parents can't take care of them because of their illicit drug use, okay? In Indiana, in 2015, we saw 17,000 children placed in foster care. So we have major issues. So our area of focus for the Marion County Health Department is we really want to do harm reduction programs to address how transmission occurs in the real world. We're strongly looking at syringe exchange program being brought to Marion County that we need to look at. We're already doing the medication-assisted therapy that Dr. Brucker talked about. We do the training for folks out in the communities in terms of how to use a Narcan and providing kits out there for folks who are eligible about it. But we've got to reduce the stigma so that those who need to get into treatment can get into treatment, and they need to be able to get into treatment on demand. We've got to let them come in when they're ready to come. We wait a week, 2 weeks later, we might have lost them. Now, I was at a fabulous annual event last night, Pathway to Recovery. And I heard this remarkable story about a young white male married his high school sweetheart, had a fantastic job, had wonderful children, and because he got hooked on the drugs, he went from job to job, and eventually he just couldn't keep his job because he couldn't make it to work every day on time, and even when he was there, was not functioning. And unfortunately, he eventually lost his wife and his children. You know, she just, I can't take it anymore, and whatever. And it turns out it's so bad, you know, got arrested, and, you know, occasions that he finally, his father came and said he told his son, hey, I'm going to move in with you, and let me just move in with you for a little while and see if we can get you straightened out or whatever. But what the father later told his other brother, who told us, and his other brother was telling the story, is that despite everything, and they tried to get him help repeatedly and whatever and weren't successful, was that he went to live with his son because he didn't want his son to die alone. Okay? I just can't let my son die alone. You know, and he's going to continue to do this, but he got in the Pathway to Recovery, and I believe he's 2 years now sober. So a remarkable story, but just heartbreaking. So we've got to work on how we remove the stigma to get them into treatment, look at the different strategies, and we have to understand from a prevention standpoint how to make this happen. So we know with syringe exchange that people inject drugs, if they are provided the supplies, it will cut down on their transmission of HIV. It will cut down on their transmission for hepatitis C. But the most important thing is, instead of them discarding and throwing it in the streets, or for any kid to pick up these contaminated needles, they now are being disposed properly. There are 228 syringe exchanges in the United States. That was July 2013, when there was only one in the state of Indiana. We now have 8 syringe exchange programs in the state of Indiana, and it's increased significantly. But the value of this program is that it allows those individuals to be exposed to someone for testing and counseling for those who test positive, and get them into addiction services, okay, if they trust you. People who use syringe exchanges are 5 times more likely to get into treatment. And that's our key. We've got to get them in treatment. We've also proven that it reduces hepatitis C, and it's been proven by different governmental agencies that it does not lead to more drug use, but referrals to treatment, medical care, when those things are provided with it. And so, according to the National Institute of Health, access to clean needles reduces risky behaviors by as much as 80%. Okay, and we can keep clean streets. We really want to produce mom from becoming HIV infected and spreading it to a newborn baby. Okay, so got to prevent that transmission. We also know that if those cities with syringe exchange programs, they saw a decrease of HIV transmission by 6% yearly. Cities without syringe exchanges increased their HIV transmission of nearly 6%, increased it. In Washington, D.C., their HIV cases linked to their injection drug use dropped by 80% from 2007 to 2011. So the cost-effective hepatitis C treatment, up to $300,000 per person. That's if you ended up needing a liver transplant. 60 to 80,000, we can cure hepatitis C now, but the cost is $60 to $80,000. HIV, average cost is almost $400,000. So preventing these drug-related infections is 150 times more cost-efficient for us preventing the disease, as opposed to I've got to wait till they have the infection, and now I've got to treat them, which can be extremely expensive. I'll thank you very much.
Thank you, Doctor. We have a few minutes left for questions. I'm sure you've got some written down after that. Two excellent presentations. I'll open it up. Yes, ma'am?
Can you hear me?
Absolutely.
Yes.
It's more important they hear you, but I'll repeat it if everybody else can't. Step on up. It's like American Idol.
Well, just today on mine, I saw that even small towns with 5,000 to 20,000 people, CVS was getting a whole lot of those. The robberies? Yeah. And more than anybody would need. And so those were being peddled. And then what I learned was people that worked in drug enforcement for years, some up to 30 years, have gone to working for the pharmaceutical industries, and they managed to get both the House and the Senate to deregulate a whole lot of what they were doing. They fired a real tough man that stood by real benefits. And now it's real easy to get oxycodone and sell it. And CVS was in a big spot there.
Yes. You can stay back there.
Thank you. I just wanted to ask, at Eskenazi, how effective is the VA in cooperating with you? You didn't acknowledge Rada Bush on your thank yous. And I just wonder if a lot of these veterans with PTSD are showing up with, you know, self-medicating with heroin. What is the VA partnering with you to deal with those guys?
So the VA actually has led the way on a lot of important research in this area. There's a very robust medication-assisted therapy program there, as well as a therapy program. And so the veterans it's relatively straightforward to get someone into care there. Not all veterans want to receive their care through the VA for lots of complicated reasons. So, or maybe not so complicated, but that it's not really an administrative issue of getting people in. It's more of a cultural issue about helping people bridge from cycles of active addiction into taking these baby steps and then hopefully engaging in organized care.
Sir, now come right to you.
Yeah, yesterday on 60 Minutes, they talked about this opioid problem was real big. They had a nice program on it. And they said the industry that allowed millions and millions of drugs to go into office, pharmacy offices and doctor's offices that distribute the drugs to people who had no legitimate use for them. And two of the companies they talked about was McKinsey and Cardinal Health.
It's all true, and it's really bad. And when I was in medical school, they taught us that OxyContin was safe and non-addictive. So that was all lobbying from the drug companies. So you have a whole generation of physicians who are trained to treat pain as the fifth vital sign. It convinced a whole generation of patients that they shouldn't have to suffer because no pain, you shouldn't have to be in any pain all the time. And then they paid an army of lobbyists, usually young and very attractive, and would buy lunch for the whole office to sort of hand these pills out. So there's no question that the drug companies, insurance companies, and the healthcare systems kind of have a huge hand to play in this.
So she's...
I will tell you, just to follow up on that, Dr. Brucker mentioned in her presentation, she mentioned the word inspect. Certainly doctors and pharmaceutical companies are willingly doing it, but inspect has been a really good tool for prosecutors and doctors to stop patients from going from doctor to doctor to doctor to doctor to doctor. Because it allows all the doctors and prosecutors, law enforcement, everybody to see where everybody's been.
It's a red flag.
Exactly. Yeah. Exactly. They can't use it in prosecution, but they can use it so that they can't jump from doctor to doctor. Ma'am, question?
Thank you. And I thank all of you for your service, because I admire you and you being so young to know it. But Dr. K, that voice, but tell me, with all of this, the help that they get, how do you break the addiction? You know, some things are just habit-oriented, so those medicines, do they just give them the cycle of the habit that they shoot up that help break the addiction? What does that look like?
So all of the medications that are, well, the two, buprenorphine, Suboxone, and methadone, the whole idea is that drugs are addictive because of that high and low. So your brain likes that spike, that big dopamine spike is what it likes. So when you replace that hill, that mountain, you know, that peak and valley with a constant here, you allow your brain to start the recovery process. So it doesn't happen overnight, right? So you're gonna take those big spikes away and you're gonna level it out like this, and then you're gonna do a lot of hard work in terms of rebuilding relationships, reforming community, refinding family. All of that work still has to happen. But as long as you're doing this up and down, up and down, up and down, and heroin withdrawal, I hope no one in here has experienced it, but it is awful. You would not let someone that you love go through that for no reason. And so people really feel awful. They feel like they're absolutely going to die. And so and they know, I mean, unfortunately, the people who provide heroin are no more than a text message away. So when Dr. Kane says you have to get them in, you have to be faster, you have to be more available than their drug dealer, which is a really hard challenge for a big healthcare system.
So just been the white hat.
Just let me say, we'll take about 4 or 5 more questions because we're way past time. I know Amy's probably giving me the hook. But I would guess maybe that you guys will stay around. If you don't get your question, you can come up and individually get one, maybe. Yes.
Okay.
I want to ask a question because I think many people in this room above average are either carrying naloxone kits or they've been trained to do the stabilization intervention to save lives. But at the intersection of the Good Samaritan law, doctors and lawyers versus malpractice and immunity, could you talk a little bit about, are we immunized if we intervene and try to stabilize to save a life?
Okay, so I'll speak to what I know, and I guess with some caveat that I'm not an attorney or a prosecutor. So, but I'll say that the Good Samaritan law will definitely protect you from if you're using it to help someone, and it will also protect the patient for that incident. The problem that we run into with our patients is that they often have outstanding warrants. And so that Good Samaritan law, so sometimes you'll see people getting arrested and you're thinking, what's going on? It's for an outstanding warrant. And as a physician and a caretaker, I'm thinking, like, what are you doing? I'm trying to get this person into care and you're putting them in jail. But you have no idea what the warrant is for. So if the warrant's for dealing, you know, or homicide or something else, then it just gets very complicated very quickly. I think I can say with certainty that you're protected as a bystander who's trying to help.
Correct.
I think Justice Chan.
Thank you. I think about this a lot. I have a teenager and I look at him and look at all his friends. He's 14 years old and I just see this, you know, in our society, and nobody is immune, and don't fool yourself for a second. You know, you can put everything you have into your children, but this is a real concern for our whole community. I would love, love, love to see this education, preventative education in our high schools and in our junior high schools before, treated before, it'd be a lot cheaper and a lot healthier and be a lot better for our families. We start treating this before problems become.
I totally agree, and the median age of first drug use in our overdose patients is 13. So high school is too late. High school's too late.
And just want to emphasize, a lot of these kids are having post-traumatic stress disorder in some of these neighborhoods at a real early age. It's not about the veterans from war, but right here in their own neighborhoods. Yes?
Two questions, hopefully. One is,
Louder.
why do you think African Americans at this time have a less rate? And the 46218, I noticed the darkened area. Do we know, is it public knowledge, the data around the addresses of where those overdoses happen?
So let me say, so you're trying to ask why is it higher in the white population than the African American
Do
population?
we know why?
Do we know why?
Not really.
So you know, I think we have to think about social media, whether we like it or not. I think we have to think about social media. I also think we have to think about it from a poverty standpoint too. So our white counterparts, is it easier for them to acquire the drugs compared to some of our African Americans that it may be a poverty issue? Now, you know, to get a heroin hit, it's just like $10. And we used to be drug prescriptions, but might cost me $100, but I can get a heroin hit, $10, $20 on this piece of cake. But they are losing their heart valves. They get bacterial infections on their heart valves, and these young 20-year-olds have to have a complete heart valve replaced. It is just scary and frightening.
I'm glad you
Yes.
talked about the cardiovascular effects of the drugs. I'm glad you mentioned that. Please, Dr. King, thank you.
Yes, I'm sorry.
I have a question about disposal of drugs. That I was in a palliative care situation, taking care of someone in palliative care who was being prescribed heavy amounts of opiates, morphine, and so forth to take care of acute pain. And we had to make sure to dispose of the drugs that remained afterwards. So I wondered if anyone of you could address that and get the information people here about
Kitty
how
litter.
this is. Well, there is a way where I was taking care of the person. I went to the police, and they had a box, a metal box, like a mailbox, in the lobby of the police department, where you could just drop the drugs anonymously and just get rid of them, and they were properly disposed of.
So we have a number of sites throughout Marion County where you can dispose of medications. I know you can call my office, 221-2000, and they can tell you the locations of where those sites are, but that's definitely available.
The Ashkenazi pharmacies, you can take them back to.
Okay. Quick, well, you got two. There's two right here, guys. No, the gentleman in front of you and the lady behind. Quick.
Dr. Brucker, in your presentation, you made mention of overdose victims that then received additional prescriptions. Does HIPAA preclude you from notification of primary caregivers that they've been treated?
That's a great question. HIPAA is a very complicated issue around substance use disorder. You can send something through Inspect to the providers. You could, in theory, probably, it would be fine to talk to a primary care doctor, but most of these patients aren't forthcoming with that information, and so it's hard to do. And then if you send it through Inspect, you're relying on the person, it's usually more than one provider, you're relying on all of them to get that message and act on it. So Inspect is a great tool, but it's widely underutilized.
Your last one.
So with Marion County having numbers almost 5 times greater than the U.S. average, what are we behind the ball? It took too long to get there? Are we missing something? What's the issue?
So what I will tell you is listen, opioid crisis is going across every community across the country. And it just seemed like it's really hit us like the last 2 or 3 years. is just taking a leap. Part of that may be related to how sophisticated they are in getting the drugs here to our folks, but I also think we have to think about several things. We have to think about our poverty level, what makes people vulnerable. So how good are our jobs? So you may have a job, but is it a living wage job, meaning that you're making enough that I can survive? So I think we have to look at all those kind of issues. We have food insecurity that occurs here as well. So what makes us vulnerable? And I also think our mental health, we've got to address that. We're way higher than the national average, so we need to take away some of the causes of why people want to self-medicate themselves. Providers, we got to do a better job. We need to know how to treat pain and what's the appropriate day that we got to just cut that pain medicine and say, hey, you got to suffer a little bit because I don't want you addicted. Providers, we're not as good as that. We're training. We're happy to hear that IU is going to be spending about $50 million trying to look at the different interventions that will work for opioid crisis. We know that the state, Jim McClellan, and our governor is doing a huge push on that. So look to see some major changes. So there are a whole host of different interventions, but we need your help, we need your support on some of these interventions that can work in our communities, and we can't do it without each and every one of you. Thank you.